So in Kenya, we've made quite some strides in the area of cesarean section. There has been a lot of programming that have focused especially on access. But now the challenge that remained was the issue around quality.
As a county, we perform about 4,000 cesarean sections in a year. Natural birth is usually preferred, but in as much as they have complications, there are patients who really need cesarean sections, and if they are not performed, then we end up with a bad outcome. Of the mothers that died in 2020, about 70% of those mothers had had a cesarean section. As a county, we are only 3 obstetrician gynecologists, and we have 9 facilities. So only 2 of those facilities are being managed by obstetrician gynecologists. So the other 7 are manned by medical officers. And medical officers are junior colleagues in the training. They have not specialized in obstetrics and gynecology. So there's a dire need to train these medical officers to be able to do the procedure the right way and to prevent complications, and then to be able to manage complications in case they arise.
Makueni County is on the southeastern part of the country. A very good community that is hospitable and kind. And as Jepaigo, we like to work in Makueni because it's one of the counties that we already have investment through other programs.
My name is Mary Mudengi. I'm a technical officer. Currently, I'm working as a technical officer for Obstetrics Safe Surgery funded by Johnson & Johnson. The aim of the program is to improve access to safe obstetrical, surgical care and anesthesia care in Kenya.
I would say the first time Obstetrics Safe Surgery came to Kenya was in 2018, but really WHO was the main prompt. Jepaigo at the global level was able to pick up that and start focusing on it.
There was no curriculum for obstetric safe surgery in Kenya. So we had to go down and involve all the stakeholders. We had the Department of Reproductive and Maternal Services involved in this. We had Kenya Society of Anesthesiologists. We had Kenyatta National Hospital. We had training institutions, and we had Makueni County representatives who came on board, and also the Kenya Obstetrical and Gynecology Society, who had to come and validate the curriculum for the country.
Now you need to understand that in Kenya we have like 225 physicians. We are talking about a population of 50 million, okay? Globally, WHO recommends that 1 physician to 1,000 patients, or rather 1,000 people. So that is a ratio of 1 physician to 222,000 patients. It's not possible. So for us to make sure, as Kenya Society of Anesthesiologists, to make sure that we offer quality and safe anesthesia to every Kenyan, yeah? So we come in to fill in the gap by giving education, trainings, and workshops to the non-physicians. And actually that is why this course, this training is very important.
Actually, Obstetrics Safe Surgery is the best program so far, because before we were not keen on training the surgical teams, especially the anesthesia care, which has been lacking in Kenyan systems, and the teamwork which was there in theaters. So for Obstetrics Safe Surgery, we have taken care of the team cohesiveness, which is very key in care of patients and safety.
Actually, when we were in college, there was a joke we used to make at anesthetists are the unsung heroes. Actually, in theater, we are the drivers. Surgery cannot start if the patient is not under anesthesia?
Initially, this is a very highly specialized area that had been just left to the obstetrician and anesthetist in theater. The two work very independently, and bringing these two teams together and telling them that they have to work together was quite a challenge. Some people also thought having a team-based approach to this training of obstetric safe surgery was a challenge. But we were able to bring all these teams together and agree and come up with a curriculum that serves to train these providers in a more holistic way, which is team-based.
I've been working in this mother-child now for 7 years. Professionally, I've been in the profession for 32 years. Good morning. This ward is where we keep our post-cesarean section mothers. They are taken care of, they are given IV fluids, they are given their treatment. We counsel them on self-care, breastfeeding, family planning, so that at least they space the babies. They don't come back after 1 year. A group of people, the doctors, Dr. Mbidi and medical officers and the anesthetists, they went for a training, and then they were trained, then they come and briefed us.
So one of the unique things about the obstetric safe surgery training is that it's more of a skills-based training, where we do more of practicals. We actually have very few lectures and very short lectures, but the practicals are what occupies the day. When the teams practice on the mannequins and they are not in a hurry, when you're doing it on a real life, you have to be in a hurry because you're saving lives. So when they're practicing it, they are relaxed. We correct them as they go on. And then we are able to get them have the right skill before they can actually go back to the facilities and practice it. Yeah, so in the training, there were many new things that we learned that we are going to come and implement. One was the use of the WHO surgical safety checklist. So that is a checklist that has been in existence, but as a facility and as a county, we are not using it.
Okay, my name is Maureen Lezeni. I'll be operating a surgical safety checklist for now. Sterility of equipments?
Yes, sir.
Confirmed. Anesthesia machine check?
Done.
Okay. Pulse oximeter of the patient?
Yes.
Saturating at?
95%.
95%.
The vaginal cleansing was something that we were not doing before. The prevention of infections following surgery, we were able to implement the proper use of the antibiotic prophylaxis that we give. Then immediate initiation of breastfeeding and skin-to-skin contact after the baby is born. That never used to happen in our theaters. Yeah, then the other thing was about surgical site infections and tracking. We were informed that we should track these patients for after 7 days and after 30 days because most of those infections happen in the community after discharge.
Nasema si kuongopa juu nilikuwa nataka mtoto. Juu nilikuwa nimepoteza wangapi? 3. Sasa nikasema chenye nitaambiwa na daktari ndicho nitakubali. Juu sasa nikipoteza mtoto mwingine wa 4, sasa sitakuwa na raha. So si kuongopa. Ni kitu muhimu sana Milka na Karo na daktari kukuja kuniona. Juu kuna vyenye naweza misuse kidonda. Wanakuja wananiambia vyenye napaswa kutunza kidonda isiingie maji. Vyenye kitovu ya mtoto napaswa kuipanguza. Yani ni wazuri.
They say learning is a continuous process. Until you go back to class, that's when you will learn that, I've been doing this and this is the way it's supposed to be done. Now, the training opens up our mind in one way or the other.
The rates of cesarean sections are increasing. As a country, we are not able to put an obstetrician gynecologist whenever there is a theatre for cesarean sections. Most of the trainings that we have is you train in school, you do an internship of like 1 year, and then now you're released to go and practice. And most times you are like the medical officer in a small facility and you are on your own. So it's very important that we target these medical officers, train them and refine their skills as they continue practicing in those facilities.
Ultimately, this project is a win-win situation. We get a happy mother who has a live and well baby, but more importantly, the community will be celebrating that she's safe, she's fine. We know that the mothers are really the backbone for any communities, and we need them to get out of the surgery safe and alive.
Makueni is a pilot county. We are very pleased to say that there has been documented progress in our program implementation. And by the end of it all, we are very sure that the country will take it up. The county has taken it up because they supported even one extra class. We have trained 29 healthcare providers for that.
They say knowledge is power. I'm powerful.